Good evening, everybody. This is Brother Wolf, and this is HS 375. Tonight we have the group 2 that's going to cover managing acute care hospitals. Now, it's really important that you listen to the whole presentation and the comments all the way through the end, because this material is material that will probably be covered on the exam that's coming up. So I will turn the time over to Group 2, and I think Megan's starting whenever you're ready.
All right, so we are doing Managing Acute Care, the hospital's presentation. Let's see. So the first one was, what is a hospital? And that's pretty easy since it's pretty familiar all around everywhere. But it's an institution or an organization that provides medical or surgical treatments for the injured or sick in both outpatient and inpatient care. The history on it, a lot of people already know this, but the majority of those that kind of came to America, they wanted freedom, not only, you know, with everything, but especially in their religion. And so back then, religion played a huge part in everything, including the healthcare. So most of the hospitals that began back then were operated by nuns. And so in order to control that power, the government had to secularize the public institutions and kind of diminish the role of religious affiliations because they didn't want too much control. So throughout the early years in history, the American history, and even into the 19th century, most people had their illnesses, or they gave birth, or they did their surgeries at home. I know this is kind of religious, but the first thing I thought of when I was reading that and researching it, I thought of Joseph Smith and his surgery that he had on his leg. Hospitals emerged from institutions called almshouses, and those were charitable care institutions or homes that took care of the ill and poor and disabled. So this is on the far right, that one of the first hospitals in the American colonies was this one, and it was founded by Benjamin Franklin and Dr. Thomas Bond in 1751, and it provided medical treatments there, and was one of the first surgical amphitheaters, along with the medical library, the first medical library. So it was charitably funded, and it has served a lot of people in the war, wounded. So kind of a quick history, around the 1880s, sterilization became better understood, which opened a door for surgeons and the medical world. So the Bill of Rights, the 16th Amendment, they passed the charitable contributions of 1917 for tax deductions. So that was huge. And in the 1920s, hospitals began to be a place of hope to be cured. Not-for-profit hospitals began to compete with public hospitals with intent to kind of attract the middle class, and religion was a huge springboard to help these nonprofit organizations. So doctors and nurses also began to donate their time, but also they were getting compensated for it, and it was professionalized, meaning that they actually had certain requirements that they had to meet in order to be in those places. So the Great Depression hit, and there begins to be a shift kind of in privately owned hospitals and public institutions. So there's a great increase in patients being seen in hospitals, and people turn to new methods to use this, including insurance plans. So in 1965, President Johnson and the Congress start the Medicaid and Medicare. And then in 1968, the largest for-profit operator in the world, which is HCA, or Hospital Corporation of America, is founded in Tennessee. And the picture on the right is Dr. Thomas Frist and his son, or senior and junior. And so their hospitals, the HCA started to grow tremendously in the 1970s and 1980s because they were able to acquire a lot of hospitals that weren't able to make it in that. In 1970, the American Hospital Association listed 7,123 hospitals in the United States, which in 1960 it was only 247, so there was a huge growth there. And then in the 1980s, there was also the growth for for-profit hospitals, as the smaller community hospitals were closing. So larger hospital systems were forming entities and owning more and operating more than one hospital. So the National Association of Public Hospitals was established, and they started to serve low-income patients. And so that brought in billions of dollars for hospitals, which is great. In the 1990s, they started doing GPOs, group purchasing organizations that offered discounts and to all different types, including hospitals. So today now we see lots of hospitals that did serve poor, the nation's poor. They closed their doors, and the rising cost has forced many of the hospitals to close. So government has come together, and they did the Obamacare, which is also called the Patient Protection and Affordability Care Act, to try to lower the cost and improve quality care. And then though HCA has been scrutinized and kind of has had their legal issues, it still continues to be a leading model for the hospital organizations around the world, or worldwide.
All right. Classification of hospitals. There's a lot of different ways to classify hospitals. You have public hospitals that are owned by the government, non-profit, and they also receive funding from the government. And you also have private hospitals who are owned by medical groups, groups of physicians, or private individuals. And they can be, private hospitals can be non-profit or for-profit hospitals. And then you have community hospitals and non-community hospitals. And community hospitals are located in smaller towns. They play a large part in the community, and they only acute care provider in the area. And then you have non-community, which are located in metropolitan areas and large towns, and one of the many acute care providers in the area. Then you have for-profit hospitals, and 1/3 of hospitals make up the for-profit hospitals, and for-profit hospitals focus on making money, of course, and they also, because of them being for-profit, they are required to pay taxes and dividends. And then you have non-profit hospitals, which make up 2/3 of American hospitals, and they focus on providing needed care. They receive the tax breaks or benefits, and the profit that gets reinvested into the hospital for better equipment and those type of things, and they receive donations from the public, and most are religious based. And then there's a different way of classifying hospitals based on the number of beds that they have in the hospital, and you can see that list of generally the ranges of what they are classified as. Next slide. And then you have rural hospitals, and the vast majority of rural hospitals are critical access hospitals. And you have urban hospitals, and the vast majority are disproportionate shareholders, or share hospitals. I'll touch more on that on the next slide, or the one after this. So you have critical access hospitals, and in order to be classified as a critical access hospital, they must contain 25 beds or fewer, and they must be located within 35 miles from the regular full-service hospital. And then you have certified to receive cost-based reimbursement by CMS, and must have 24-hour emergency services. And then disproportionate share hospitals, the hospital serves a higher percentage Medicare patients than it does any other patients, or greater than 30% of inpatient revenues come from state and local governments for indigent care. And they're located in more urban areas, but these hospitals, the disproportionate hospitals are mainly for lower income hospitals, so those hospitals that serve a large population of lower income patients. And then you have advocacy and representation, and there are many advocacy organizations that are established for different areas of healthcare departments to assist for healthcare organizations, and these can be either for-profit or not-for-profit healthcare organizations. And hospital organizations are arguably one of the most competitive markets and complex industries. And with the constant establishment of new legislative laws, complex billing requirements, and the many variations in provider specialties and procedures, you can see why it is important to have access to advocacy organizations to better adapt to those type of changes. Both not-for-profit and for-profit hospital organizations have an advocate, and you have the AHA, or American Hospital Association, which represents the legal and political interests of not-for-profit hospital organizations. And you also have the Federation of American Hospitals, which represents the legal and political interests of for-profit hospital organizations. And then, next person.
Okay, the statistics of acute care. There's a total registered hospitals are 5,686. Out of those hospitals, there's 4,974 that are community, 2,904 that are non-government, not-for-profit, 1,060 for-profit hospitals, and 1,010 state and local government-run hospitals. It is important to note that these numbers change often, and so it's hard to keep the statistics current. Next slide. In a multi-hospital system, the definition of a multi-hospital system is 2 or more hospitals owned, leased, sponsored, or contract managed by a central organization. There are 3,144 multi-hospital systems, and some of the largest ones are Hospital Corporation of America, Community Health Systems, Tenet Health, Ascension, and Trinity Health. Integrated healthcare networks are a group of hospitals, physicians, other providers, insurers, and or community agencies that work together to coordinate and deliver a broad spectrum of services to their community. There are 1,582 integrated healthcare networks. The ones that you might know are Intermountain Continuing Medical Education, Healthcare, and Adventist Health, Legacy Health, and then there's also multi-health care system in Washington. Next slide. Levels of acute care. There are 3 levels of acute care, and it's important to remember that there are only 3 levels. They are tertiary, secondary, and primary, and the following slides will show what each one are. Next slide. Tertiary care it's more of a hospital specialty training, where the physicians are, where the physicians and the staff have a specialty, and examples of that are trauma surgery, oncology, neurology, and they also use higher levels of or advanced machinery and higher levels of care for tertiary. Next slide. Secondary acute care. This is known as where a physician can refer you to have specialty care. So those type of physicians would be oncologists, gastroenterologists, neurologists, that sort of doctor. And these referrals come from your regular family physician, or if you were to go into the emergency room, and an emergency department physician could also refer you to a specialist. Primary acute care is where you go and visit your primary physician, or you go directly to the emergency room and see a physician there. Some of the examples are just what I said. It's where you go and have just a regular visit with your family doctor, or you see a physician in the emergency room. I think this is somebody else. I think this is Jeremy.
Sorry, I was on mute. All right, reimbursement. Reimbursement is definitely one of the most important things to understand if you're planning on pursuing a career working in a healthcare provider organization. The business office handles the coding, billing, and collections. And if you remember, I think it was in either week 1 or week 2, we read about a certain hospital that was losing money year over year, and after having multiple changes in their C-suite executives and reorganizing the governing board with new fiduciaries, the hospital finally figured out the issue when another nearby hospital organization got involved. And it really didn't take long for them to find out that the hospital wasn't doing their billing correctly. So it's very important to understand that. And however, billing insurances isn't as simple as it sounds. It requires categorizing care into service codes, creating an accurate bill, and billing the patients and insurance companies for services rendered, and collecting for those billed services. We should also know the type of billing and collections that are acceptable. First, we have CMS, or Centers for Medicare and Medicaid Services. In this case, hospitals participating in Medicare must meet certain specified requirements in order to treat CMS patients. And then second, we have commercial health insurance, which is any type of health benefit not obtained from Medicare or Medicaid. This insurance may be obtained through an employer or can be privately purchased. And then the last one is pretty self-explanatory. Private pay by patients. This isn't very common, but it's when patients choose to pay for the costs of the care out of pocket. That's it.
Okay. The next few slides will explain the difference between private practice versus hospital-based physicians. According to the Medical Group Management Association, in 2002, about 20% of physicians in the U.S. were practicing in U.S. physicians' practices were hospital-owned. In 2008, that figure was over 50%. There are some pros and cons for physicians that choose to move to hospitals instead of managing their own practice. Hospital pros are that they virtually are assured an income. They don't have to worry about whether they're going to receive enough money to have, to be able to get paid. There are no worries about the administrative duties, so they don't have to worry about managing a staff or making sure the bills are paid or any of those things. Their incomes are often higher when they move to a hospital than if they were to just stay at their own private practice. The hospital cons for physicians moving to hospitals are the doctors can't be in charge. They're usually supervised by somebody else, and so that's one con. Hospitals could change the doctor's compensation, so the level that they decide to pay the doctor could change, and so that is a con also. Then when physicians move to hospitals, there is that if they move their practice patients to the hospital system, then they've got their electronic health records that they've got to move and try to incorporate into the hospital system. Also, doctors tend to view or sometimes view the health care a different way than the hospital views it, and so they might not agree, and so that could be a negative for doctors in moving to hospitals. Some other reasons why physicians move to hospitals are a declining reimbursement rate from Medicare and Medicaid. Lately, we've seen that Medicare tends to pay hospitals more in reimbursement than they do physicians who own their own practices. Physicians also have lower bargaining power against in being able to bargain with insurance companies and Medicare and Medicaid to be able to get their payment. Another reason why physicians move to hospitals are because of lifestyle considerations, which means they want to have less responsibility of not having to manage a staff or worry about paying bills for equipment and office and medical supplies. Also, they show that physicians tend to transition there are reports of positive benefits from other physicians who have transitioned to employment. So physicians hear from their physician friends that working at a hospital is much better than owning their own practice, and so many of the other physicians will move to a hospital instead of running their own practice. There are doctors that start to grow older and they're wanting to get out of the business, and so they are looking for a way to get out of their private practice, and one way is to move to a hospital and be employed by a hospital instead. The perception that employment offers the opportunity to lock in compensation at an existing level is also one of the reasons why physicians will move to hospitals, and then they don't have to worry about how much they're going to get paid or if enough money is going to come in for them to get paid. There's also some uncertainty for physicians who have their own practices with the different things that are happening with the Patient Protection and Affordable Care Act. And so physicians just don't want to have to deal with that, and the easiest way for them to do that is to just move to hospital employment. Next slide. The next couple of slides will go over hospital financial statements. There are 5 statements that most hospitals have. The first one is the income statement. The income statement will start by displaying the total revenue, and then it will deduct costs and show the gross profit for the hospital. then it will take away the operating income and expenses, and then it will also show the net income. So net income is minus the goods, the services, the expenses, and the taxes from the total revenue. The next financial statement is the balance sheet. And there's three things that show on the balance sheet, or three main important things, are assets, liabilities, and stockholders' equity. The assets are the resources that the hospital owns, and the liabilities are the debts, and stockholder equity is the shares that the company has. Usually, or on a balance sheet, assets always equal liabilities plus stockholders' equity. The next statement is a cash flow statement, and it's just what it sounds like. It shows the flow of cash in and out that the hospital receives and pays out through operating, investing, and financing activities. The operating activities are, could you go back one slide, Megan? The operating activities usually are products that they sell, services they sell. So for hospitals, it would be their care. Investing activities are the investments like in their land and their buildings. And financing activities are if they were to get a loan or that sort of thing. The fourth statement is the statement of stockholders' equity, and this shows all the shares or the stocks that are being sold and bought and issued. It also shows the net income, and many of the stockholders are either paid with money or with stocks. The final statement is fixed asset file. This file is where they record the fixed assets, and examples of fixed assets are land, buildings, medical equipment, office equipment, furniture, fixtures, and vehicles.
Okay. In the interest of time, I'm going to be kind of quick here. Hospital governance. A good working definition of hospital governance is an establishment of policies and the continuous monitoring of their proper implementation. This is done by the governing board. It's a way for them to balance the powers between different members and different branches of the hospital, and also to enhance the prosperity and the viability of their organization. So just kind of basically, acute care facilities tend to have larger and more complex chains of command because there are more employees, because there are more different divisions within the facility. Just kind of by the nature of the acute care facility, they tend to be larger and more complex. I'm going to hold off on going into some of the departments and other groups because we have a little bit more of that later on in the presentation. But this process of duties and different people reporting to people above them goes all the way up to the CEO. The CEO, of course, answers directly to the board. And without effective governance, a hospital cannot be financially viable or provide quality care. This is a chart, just kind of a general, I guess, a flow chart of how the governance takes place. And you're actually going to see a much more in-depth and well put together version of this later on in the presentation. So next slide. Okay, the impact of legislation on hospital management. I'm just going to touch on the few that I thought were particularly interesting. We know, and we have been talking a lot about the Patient Protection and Affordable Care Act, and a lot of these different acts that I'm going to be talking about are actually amending that act or the Social Security Act, Medicare, things like that. One I wanted to touch on specifically is the HITECH Act. It stands for Health Information Technology for Economic and Clinical Health. And basically what it does is it promotes the adoption and meaningful use of health information technology. So there's a big push for um, all the charting, all of the information for patients and for doctors to be done in an electronic setting so that it can be shared more easily, so that it can be used to the best of its ability. I want to skip down to the Registered Nurse Staff or Safe Staffing Act of 2015. This is one that hasn't been put into law yet, but it's something that could affect the future of hospital management. And basically what it does is it requires an appropriate number of registered nurses to provide direct patient care for each unit. And so when we have laws that are dictating how many people we have to have, you know, to provide that high quality of care, that's something to look forward to and something that I think will help increase the overall level of care for patients. The last one is the Rural Emergency Acute Care Hospital Act. This one is kind of a cool act. What it does is it allows Medicare Part B to cover rural emergency hospitals services. So ambulances, some home care for like oncology patients, things like that. Things where it might be difficult for patients to go in to the hospital in a rural setting. It will allow for a greater freedom for physicians to care for their patients the way that they think they should instead of the way that they will be paid for. So it basically just allows doctors to really do their job without having to worry so much about whether a certain service is going to be coming out of their pocket or will be reimbursed by the government or by another payment entity. So next slide.
All right, so we've heard multiple times in this course and other courses from Peter Drucker that the hospital or the hospital is the most complex human organization ever devised. So we're going to try and make that a little bit easier. So the organization of hospitals follows a basic chain of command. That way there's usually or hopefully a clear understanding of who is responsible for what part of the hospital's operations. The departments in a hospital are normally grouped based on similar duties that they perform. So imaging and things like that. And 5 of those common categories will be administration, information services, therapy services, diagnostic, and so underneath each of those will be similarly grouped sub-departments. So next slide. As Nick alluded to earlier, there is a pretty clear organization in hospitals. The main piece is going to be the top there, the governing board. They have the fiduciary or legal responsibility for the operation of the facility. And then it goes on down the line to your administrator, your president or CEO. The names can change depending on what style of organization is being followed, whether it be C-suite or some of the other options out there. So below them, you have your CFO or your vice president, and then on down the line until we get to the department heads of each of those, normally those 5 departments we discussed earlier. Next slide. Within the healthcare industry, especially with hospitals, there are a lot of professional organizations that are designed to help healthcare professionals to advance their knowledge and understanding and continue to be on top of the ever-changing healthcare world. And so we will go over just a few of those. I think there's 4 that we have to go over. But there's a lot of information if you can do a quick Google search and find multiple different organizations like this. So the first is the American Hospital Association, which we talked about earlier. They have opportunities for multiple different types of professionals. A few certifications that they offer would be a certified healthcare constructor, facility management, as well as healthcare human resources. And then you have the Association for Healthcare Administrative Professionals. This one isn't what you would think it would be. It's mainly going to be geared towards executive assistants and administrative assistants, but they do offer a certification program for them. And next slide. And the final piece for presentation is going to be these last 2 organizations. The first is going to be the American College of Healthcare Executives. They have thousands of members, and I believe from their website they have about 80 chapters across the world. And so there's most likely a local chapter. They offer an FACHE, which is a fellow of their American College of Healthcare Executives. This is a pretty prestigious certification, and it is quite difficult to attain. And then the final one is the American Association of Healthcare Administrative Management. They serve a pretty wide variety of people, but it mainly is going to surround the revenue cycle we've talked about earlier is so important to the function of the facility. And so you can see there that they have about, I think, 5 or 6 different certifications that they offer to help us become better with managing the revenue cycle and helping to keep our hospitals viable and able to function and take care of our patients. So. And that is our presentation.
Excellent. That's very well done, very thorough. Let me just kind of highlight some of the things that you talked about, and I apologize if I get it wrong who was speaking about these. But on one of the slides, you talked about kind of the number of hospitals that there are. I don't know if it was Megan or Jenny that was talking about acute care hospitals. So maybe take a step back. Acute care it really is just the medical care for somebody who's ill or injured. So as opposed to somebody who goes in and they have, let's say they have stabilized hypertension, so it's kind of a chronic condition. That's not really acute care. Acute care is if somebody's currently ill or currently injured. That's what acute care is. So acute care hospitals are those hospitals that are taking care of those people who are acutely ill or injured. And there's around 5,700, so around 5,700. I think you guys had 5,686, and you are absolutely correct. These numbers are always changing. There's, the second you quote a number, it's going to already be out of date. So just be aware of that general number of around 5,700 acute care hospitals. You also talked about the 3 levels of acuity, tertiary, secondary, and primary. And there's a term that is often used sometimes in the ER, sometimes in disaster areas, but disaster recoveries and those sorts of things. A word that describes when you separate patients into one of these 3 levels of acuity. Anyone know what that word is?
Triage.
Triage.
Yep. Yeah, triage. So I just want people to be familiar with that word. I think most people have heard that word before. A lot of us come across that word when you go to the emergency room, and there's the triage nurse. They're the one who's making that first assessment of, is this kind of a serious? Is it something that can wait? But another use of the word triage is separating patients into these 3 levels of acuity that you mentioned. The other thing I wanted just to ask is, and I don't know if you came across any of this, but how are hospitals kind of given the green light to go ahead and start seeing patients? So let's say I had a lot of money and I wanted to build a hospital and just open up the doors. What kind of regulatory things do I need to do, and where are those done?
So I can take a stab at that. So you're going to have, obviously, to get certified through your state or the entity or the place where you'll be practicing. And then there's going to be federal regulations as well. And then you would have, it's not required, but it'd be highly recommended to get certified, or if what is it? I'm gonna forget the other one now. But basically, to get certified as well,
Yeah, I mean that
you actually are a good hospital and that you follow good practices.
Yeah, exactly. So you can get an accreditation, right, by Joint Commission or other organizations. And you're right; those are not required. And really, what I was kind of fishing for there is it's a state license, right? So it's not the federal government's not the one that gives you the license. These are usually state licenses that grant the authority for a hospital to open up as an acute care hospital. And those states usually use, each state might be a little different, but just for general purposes, be aware that they usually use a set of criteria that are already set up. it's CMS's COPs, which are conditions of participation. Since that's a pretty well established set of minimum standards, a lot of states use the COPs as their basis for granting state licenses. So just be aware of that. The other thing you guys talked about with these 3 levels of acuity, you did talk about primary care, and you're accurate. You know, most of that takes place in a physician's office. Some of it can take place in the ER, and there's one other it's kind of like a mix between those two that are becoming more and more popular. They're usually not in a hospital, but you usually find them as a freestanding clinic. You think of the
like Instacare?
Urgent care?
Yeah, and urgent care centers, right. So these are urgent care centers are typically kind of outpatient buildings that either are running on the weekends or after hours or sometimes during the day, but they typically don't require, you know, an appointment, right? You just kind of show up with your urgent issue. They usually see lower acuity level patients compared to emergency rooms, but, you know, rather than going to an emergency room for, I don't know, let's say you cut your finger and you need stitches, a cheaper option and usually quicker option are these urgent care centers. So primary care is that level of care that is kind of the initial caretaker, and there are many different ways you can get primary care, but for our purposes, just consider 3 general buckets, and those are physician's office, urgent care center, or an emergency room, as you mentioned. You guys mentioned CMS and the Centers for Medicare and Medicaid Services. When it comes to Medicare, there are 4 parts. What are those parts, and do you know what the parts, the main services that each of those Medicare parts pay for?
Yes, you have 8, and so your Part A, I believe, is going to be your like hospitalization, inpatient type care.
Yep.
Part B would generally be your outpatient, so your doctor's visits and things like that. And then it would kind of skip to D, which is going to be your pharmacy, medication coverage, and then Part C is what's commonly known as Advantage plans, which are a replacement plan that basically takes A and B and sometimes D and combines it into one coverage.
Yeah. So good. So Part A is typically your inpatient care, acute care services. So hospitals really rely on Part A, right, for the majority of their Medicare funding. In general, and you're right. Part B is typically outpatient services, physician services, and actually outpatient hospital services, right? So hospitals do both inpatient and outpatient services. When they're doing outpatient services, they're usually paid for Medicare through the Part B bucket of funds. You're right. On Part D is your prescription drug program for Medicare, and Part C is the Medicare Advantage. Those are like HMOs. So traditional Medicare is fee-for-service, meaning doctor does surgery X, he gets paid, you know, $2,000. So you do a service, you get paid X amount. Where it's not really managed care as much. Whereas Part C is that Medicare Advantage, or some people call it Medicare Plus Choice. It's the Medicare Supplemental Health Insurance, and it's a managed care as opposed to traditional fee-for-service type of care. Let's see. You also talked about disproportionate share hospitals, and that was good. And I want to just kind of clarify a little bit. The strict definition of a DSH is one that cares for more than the national average of all Medicare patients. So if there's a national average of percentage of Medicare patients at a hospital nationally, let's say the national average for taking care of Medicare patients is 40% of their patient mix is Medicare. I'm just making up numbers here. Let's say it's 40%. So a disproportionate share hospital is one that their share of Medicare is greater than that national average. And then the last thing I wanted to talk about, you mentioned a lot of abbreviations. I'm not going to go over the ones that you've talked about or that we've covered in previous lessons, but be aware of some additional ones. So be aware. Remember what HFMA is? This has to do with hospital.
Healthcare Financial Management
Yeah,
Association.
exactly. So if you're looking kind of for expertise in hospital financial management, HFMA is a great organization. And what about supply chain? So supply chain is a big deal in hospitals. They have an association that they rely on. Anyone remember? This is a little bit more obscure.
Is that along the
It's the
lines of group purchasing or no?
Yeah, exactly. It's kind of the group purchasing. But the association that kind of represents that is the HSCA, Health Supply Chain Association. And then as far as providers, we know that MD is a medical doctor and RN is a registered nurse. You've probably heard of CRNAs, which is the Certified Registered Nurse Anesthetist, a DO, Doctor of Osteopathic Medicine, and a DPM, Doctor of Podiatric or Podiatric Medicine. So just kind of know some of those terms, as well as the ones that you guys mentioned. You mentioned PPACA, you mentioned the ACHE. We've talked about some others in prior lessons, the ASCA, the CASC. Those both have to do with the ambulatory surgery centers. And then the ABMS is something that I mentioned in that video that I put on at the beginning of this week. So don't forget our abbreviations. I know some people feel that's kind of of a pain to remember those, but a lot of people in medicine talk in abbreviations, so it's important to just have our memories refreshed to those. So really great job. Any last minute questions? I know I've kind of kept you kind of long.
Nope.
Nope.
No? Okay. If you'd be so kind as to post your slides on the discussion board.
Yeah, I will.
And then just kind of monitor that, see if your classmates have any questions on and I'll post this recording, but just monitor that over the next couple of days because people are going to be getting ready for the exam, and I just want to make sure they feel comfortable with the material.
Sure.
So great job.
Thank you.
Thank you.
Thanks so much. Have a good night.
Bye-bye.
Yeah.